Good evening, everyone. It's a great pleasure and welcome you all for the IPNA Endorsed Webmaster Series 2020. And today we have Dr. Goldstein, who's going to talk on AKI, all about AKI, the pathogenesis, clinical evaluation and management. A short intro on AKI, like acute kidney injury is not only important for a nephrologist, but it is also important for the whole pediatric community. And we should all remember that kidney injury is common in critically ill children, and it is definitely associated with increased mortality and long-term renal sequelae. And the definition of acute kidney injury in pediatrics is standardized based on the elevation in serum creatinine levels or decreased urine output. And pediatric AKI always presents with a wide range of clinical manifestations. And so today we have Dr. Goldstein, who's here with us to share all his knowledge on acute kidney injury. Dr. Goldstein is associated with Cincinnati Children's Hospital Medical Center, University of Cincinnati College of Medicine. His specific pediatric interest is known to everyone. It is acute kidney injury, nephrotoxicity, and acute renal replacement therapy. He is also a recipient of the Award of Critical Nephrology and also a recipient of Jeffrey Gray Memorial Award for Translational Research. Over to Dr. Goldstein to deliver his talk.
Thank you, Dr. Ganesan, and good evening to all of you. And it's a nice morning here in Cincinnati, although I think it's probably much colder than it is there. So I'm glad that we could finally get all of the logistical issues worked out so that we could share some knowledge today about acute kidney injury. So I'll be discussing the epidemiology of acute kidney injury, which has really changed over the last 20 years, especially since we have a standardized definition. Talk a little bit about some risk factor assessment, treatment and prognosis, and a little bit of information about biomarkers. So until 2002, which is now almost 2 decades ago, there were over 30 definitions for acute kidney injury in the published literature. In fact, we used to call it acute renal failure, which is why there was little research done into acute kidney disease. People often thought that the kidneys had failed, and the only research that had been done was in children who had received renal replacement therapy. There were few prospective pediatric studies. Most current data were single center, and they predated ICU technology and practice at the time. And if you look at the textbooks at that time, both in general pediatrics and in pediatric nephrology, hemolytic uremic syndrome and primary kidney disease were often cited as the most common causes. But most of the literature after 1995 was a review of literature before 1995. So it really was not updated. One important question that really changed how we thought about acute kidney injury was really all acute kidney injury created equal? There were some adult data that demonstrated small creatinine rises were associated with mortality, and that acute kidney injury was associated with mortality and length of hospitalization. And it used to be thought that acute kidney injury, it was only an outcome and not a risk factor for poor outcome, independent of severity of illness. And this really changed in when this adult study by Chertow and colleagues was published in JASN. And what Dr. Chertow and his team asked, in 20,000 adults who were hospitalized at Brigham and Women's Hospital, what rise in creatinine is independently associated with mortality? And what they found was that a 0.3 milligram per deciliter rise in creatinine had an area under the curve of 0.84, meaning that it was 84% predictive of mortality. When you look at the multivariable odds ratio in the second from the left column, you can see that a creatinine rise of 0.3 or greater conferred a 4 times odds ratio for death in these adults. This was controlled for age, race, New York Heart Classification score for heart failure, diabetes, and COPD. So what this told us at that time was that a rise of creatinine of 0.3 or greater had a higher association with mortality than any Framingham risk factor at the time. And, when you increase the rise in creatinine, say by 0.5 milligrams per deciliter, or when you increase it by 100%, doubling it, you can see a 6 times odds ratio for mortality. So what this told us was that all acute kidney injury is not equal, and what we needed was a multidimensional classification system to grade its severity, follow changes in kidney function, and standardize acute kidney injury as a hard outcome measure. We do this in many other diseases. We grade cancers, we grade intraventricular hemorrhages in our neonates, and in heart failure, we have different classifications. And so in 2002, a number of adult intensivists and nephrologists sat around a table in Vicenza, Italy, and developed the rifle criteria. And the rifle criteria, as Dr. Ganesan said, has 2 different components, either a change in GFR, a rise in creatinine, or a change in urine output, oliguria. And what was found in a systematic review of about 500,000 patients who were adult patients was the following: that patients who had rifle R, so a 6 hours of oliguria, or a 25% decrease in GFR, who had risk, had a higher mortality risk than patients without AKI. Patients who doubled their creatinine or had 12 hours of oliguria had worse outcomes than patients with R, and patients with F, which either tripled their creatinine or had 12 hours of anuria or 24 hours of oliguria, did worse than patients with I or R. And it didn't matter if these were patients with sepsis, community-acquired pneumonia, after heart surgery, the associations and the increasing association with mortality based on rifle severity always held true. But let's think about this for a second. When a patient has a 25% decrease in GFR, or even a 50% decrease in GFR, and are, say, doubling their creatinine, or when a patient has 12 hours of oliguria, those patients are not dying from the standard things we think about with kidney failure. They're not acidotic, they're not hyperkalemic, they're not hypocalcemic, they're not uremic. So what this is telling us is that the kidneys are actually potentially contributing to the poor outcome, or are telling us how sick the patient is far earlier than we would think about in end-stage kidney disease using criteria that are standard for starting chronic dialysis. So when I was at Texas Children's Hospital in Houston, we developed a modified rifle criteria for critically ill children because we had thought that since children are still growing and have different normal baseline creatinines, that we needed to modify this for children. So we created a pediatric modified rifle criteria, and then we did a study at Texas Children's looking at the sickest of our patients, those in the ICU receiving mechanical ventilation and vasoactive medications. And then we looked at an association between the maximum rifle score achieved in the first 14 days of admission or at patient discharge. Here are the rifle criteria, or the pediatric rifle criteria, and I don't want you to focus so much on them, but just understand the evolution of what has happened in pediatrics. And what we found in these 150 patients who were enrolled, remember they were all intubated on one vasoactive substance, that 82% fulfilled the criteria for acute kidney injury, with about half of those with AKI had R, and the other half had either I or F, injury or failure. And we found that patients who had I or F had increased mortality compared to patients with R or no AKI. And that's where we've differed with the adult populations. It seems that stage 2 or I and F are actually what we need, are associated with mortality, and that R, as it was originally intended, is truly risk. There was a systematic review of the P-rifle criteria in 12 studies looking at multiple different populations. And again, as I mentioned, this comprises about 10,000 patients, that patients who had I or F, that was associated with mortality or increased length of stay. Then the AKI definitions in the last part of the previous decade started to get a little more refined. So the Acute Kidney Injury Network, or AKIN criteria, look very much like rifle, but they add the 0.3 milligram per deciliter rise in serum creatinine that we learned about or was observed in the Chertow paper. And then in 2012, KDIGO, the Kidney Disease Improving Global Outcomes Initiative, convened a consensus conference to come up with and develop the first AKI guidelines. And I was privileged to be one of the 2 pediatricians who were invited to give a pediatric perspective for the KDIGO guidelines. And as of today, in 2020, this is still the definition and the staging criteria for acute kidney injury. Acute kidney injury is defined as a serum creatinine rise of at least 3.3 milligrams per deciliter or 26.5 micromoles per liter within 48 hours, or a 50% increase over baseline, or oliguria of less than 0.5 mils per kilo per hour for 6 hours. And then you can see the staging based on KDIGO 1, 2, or 3, and there's a pediatric modifier for 3 in patients who are less than 18 years of age. If their eGFR decreases to less than 35 mils per minute, that classifies them as stage 3. So how do these compare? Well, Scott Sutherland looked at Stanford University, looked at about 10,000 children and admitted both in the ICU and outside of the ICU, and compared the mortality rates and the hospitalization rate, length of stay for patients who had their AKI classified by P-rifle, by AKIN, and KDIGO. And what you can see on the mortality side to the left here in the ICU is that there is a graded response for each of the criteria. And there may be a little bit of a different ascertainment or association between AKI and mortality based on the definitions, but it's not that different between the 3. Their mortality rates outside of the ICU were very low, and there was no association between AKI and mortality. And when we look at the length of stay, there is a consistent stepwise increase in length of stay, both in the ICU and outside of the ICU, based on increasing AKI severity, irrespective of the definition. And again, there's a little bit of difference between the definitions, but based on this, after this analysis, the pediatric community recommended that KDIGO should be used as the standard for pediatric AKI as well, so that we could compare our data to the adult population. The Prospective Pediatric Acute Kidney Injury Group, or PPAKI, was established in 2012 to undertake many observational and interventional studies of acute kidney injury across the globe. And you can look at our work at www.ppaki.org, and anyone is invited to be a member of the PPAKI, and there is no fee to be a member. So one of the major undertakings of the PPAKI was the AWARE study, the assessment of worldwide acute kidney injury, renal angina, and epidemiology across the world. And you can see the centers that or the location of the centers that participated in AWARE, 32 centers, 4 continents, 9 different countries, and each center assessed the epidemiology of acute kidney injury in their pediatric ICUs for a 3-month period in January to December of 2014. Now, clearly you can see from this map that there is an overpreponderance of North American centers, but we do have data from Europe as well as Asia and Australia, New Zealand. We were unable to recruit any centers from South America or Africa, so it is important to note the predominance of North American centers. The aims were to describe pediatric AKI epidemiology and the associated outcomes in children admitted to ICUs around the world. And then we had a couple of other aims to look at the renal angina index to predict AKI severity or presence, and the determination if biomarkers could improve AKI prediction. And I won't go into those aims today. So the outcomes, the exposure was KDIGO stage 2 or 3 AKI. As I've mentioned, all previous data showed the associations with stage 2 and 3 versus 1 or no AKI. And we used either the urine output criteria or the creatinine criteria, and we're among the first to do that. And the higher of the 2 criteria was used as the maximum stage. Outcomes were 28-day mortality, and then secondary outcomes were PICU length of stay or need for mechanical ventilation. We published the AWARE data, the primary paper in the New England Journal of Medicine, now almost 4 years ago. And when we look at this cohort, it really is quite remarkable. And what I need to first do is acknowledge all of the AWARE investigators who submitted patients and their data to AWARE. They received no funding for this, and I have personally not met 1/3 of the investigators. So they provided these data without actually personally knowing us in Cincinnati. So we screened 6,800 patients over a 3-month period. There were about 1,400, 1,500 patients that did not meet the inclusion criteria or met some exclusion criteria. And we only had 54 missing subjects, which is quite remarkable. That led to about 5,200 patients. And of those, about 5% did not have adequate data for 28-day follow-up. So in the end, we were able to evaluate nearly 5,000 patients, being the largest prospective study of acute kidney injury in children reported. But there was an unknown AKI status in about 300 patients. The AKI prevalence rate was 27% for all patients. So 1 out of 4 patients in this prospective study developed acute kidney injury in the first 7 days of ICU admission. And 11.6% of patients developed stage 2 or stage 3 AKI, what we call severe AKI. 3.5% of all patients died, and that is what you see in ICU studies from around the world. So we can say that this was a representative sample of ICU patients with a 3.5% 28-day mortality rate. And what did we find? Well, there were there were 16 variables out of about 40 assessed that had a univariate association with surviving and non-surviving. And when we looked at severe AKI stage 2 or 3, 36% of the non-survivors had stage 2 AKI or 3 AKI, whereas only 10.7% of the survivors had stage 2 or 3 AKI. And then when we controlled for all the 16 variables associated with mortality, we found that stage 2 or 3 AKI conferred a 77% increased risk of mortality, and that was statistically significant in this very large study. So I think we know now we don't need to do large prospective studies of the general ICU population. With 5,000 patients evaluated, we have answered this question. And why was this study so important? Because now in children, we can say that AKI adds to the risk and is a cause of mortality, and that patients aren't just dying with their acute kidney injury. And the reason it's interesting even outside of the pediatric realm is many of these patients don't have comorbidities like the adult population, solid organ tumors, COPD, heart failure. So this really is telling us that AKI is a risk factor in and of itself. What's also very interesting is that most of the AKI that occurred in AWARE occurred in the first 4 days. There was not much of an increase in AKI after that. So that is why we're now focusing on biomarkers and risk stratification systems to identify patients who are at risk for stage 2 or 3 AKI by day 2 or 3 and have it persistent on day 2 or 3. To see if we can improve outcomes. What is also incredibly important is that most AKI studies look at patients basing the AKI on change in creatinine and neglect to look at urine output. And it's understandable. Creatinine is a discrete variable. It's easy to obtain from the electronic health record. Urine output is often not accurately assessed, and it's more difficult to extract those data electronically. But what you can see here is that stage 3 AKI has a very high association with mortality based on urine output compared to creatinine. 1 in 3 patients with urine output-based AKI, stage 3 AKI, die. 1 in 3, and that again, to remind you, is 12 hours of anuria or 24 hours of oliguria. That is, we would have never thought was associated with mortality. What's also important to know is that 18% of the patients who had urine output defined AKI did not have serum creatinine defined AKI. So we are missing about 1 in 5 patients if we only look at creatinine. Here's the Kaplan-Meier curve demonstrating that most of the severe AKI mortality is being driven by stage 3, but again, stage 2 is different than stage 1 or no AKI with worse outcomes. What about neonatal AKI? And so this has been very much sort of the last frontier of assessing acute kidney injury in children. And just like in the PICU, and as Dr. Ganesan said, there are many different factors that are, AKI is multifactorial. This is exacerbated in neonates. ECMO, bypass, prematurity, perinatal asphyxia, and just a sick septic infant in the NICU can develop neonatal AKI. And so, again, we needed to understand some basic epidemiology in terms of risk factors, prevalence, and what are the outcomes. If you looked at single center AKI experience prior to 2015, you see an incidence that ranges from about 1 in 8 to, in ECMO, almost 50%. And in every study, patients who developed AKI by any definition had significantly higher mortality rates than those with AKI. And then Dr. Jennifer Jaton, David Ashkenazi, and the Neonatal Kidney Collaborative published these data of the AWAKEN study, which was a multinational observational study of neonatal acute kidney injury. Very similar to AWARE, published in the Lancet, except that this was a retrospective study, not a prospective observational study. The neonatal AKI definition is a little different because, especially when we think about changes in creatinine for infants, with the creatinine reflecting the mother's creatinine for the first 48 to 72 hours, and differences in normal urine output, a neonatal definition was used, which was a moderate calibration of the KDIGO criteria. 24 level 2 to 4 NICUs, 3-month period of time, inclusion criteria, they had to have received at least 48 hours of IV fluids, and they had to be under 2 weeks of life. And they did not look at infants undergoing cardiopulmonary bypass, and you see the other exclusion criteria there. And so in AWAKEN, they had 4,200 or so patients that were screened, and about half of them were enrolled. The other half had the exclusion criteria I mentioned before. And after they also needed to have at least 2 serum creatinine measurements to make the diagnosis of acute kidney injury. So at the end, they were left with 2,000 patients included in the study. Again, the largest study of acute kidney injury in neonates. What they found were different acute kidney injury rates based on gestational age, which is very important and needs to be validated as we start to design studies to look at outcomes of acute kidney injury, and also interventional studies to prevent acute kidney injury based on gestational age. And what they found, very similar to AWARE, is that patients who died patients who had AKI had higher mortality rate, so less survival. In this group, you can see 99% of the patients who survived did not have any AKI, whereas 90% of the patients who didn't survive who had AKI survived, and the length of stay was higher for patients with AKI. When you look at the maximal stage, again, you can see a decrease in survival as the maximum AKI stage increased. And what I should also mention is the rate of acute kidney injury in AWAKEN was 27%, the same as in AWARE. So neonates have the same prevalence of AKI as older, critically ill children. And when they put all of the risk factors on bivariable analysis that were associated with mortality and putting AKI in the mix, the crude odds ratio just for AKI outside of the multivariable analysis was a 7.5 increased odds of mortality and about 15-day increase in length of stay in the NICU. And on multivariable analysis, this held true. So in neonates, acute kidney injury is independently associated with mortality. So let's talk about clinical evaluation. Again, if we are waiting for patients to become hyperkalemic, uremic, massively fluid overloaded, acidotic, then we are going to be starting our intervention very, very late. And what KDIGO recommends is this stepwise progression. In patients who are high risk, ensure normal volume status, discontinue the nephrotoxins when you can, monitor creatinine and urine output, avoid hyperglycemia. And then as we increase the stages, at stage 1 or stage 2, consider diagnostic workup for acute kidney injury. And at stage 2, check for changes in drug dosing, consider renal replacement therapy, consider ICU admission. Again, this is a much earlier stage than we would have thought of starting renal replacement therapy or ICU admission. And so this really focuses on acute kidney injury separate from end-stage kidney disease and as a critical illness. So I'm going to go through the KDIGO algorithm for how we think about acute kidney injury, and there will be some editorial comments based on pediatric considerations. So if a patient is high risk, but they don't have AKI, continue to monitor them, especially at least in the first 7 days, as I showed you before. Then if they have AKI, obviously history and examination, tests, lab values, stage the AKI. And if they have decreased kidney perfusion, then you have to determine, are they fluid depleted? Do they have heart insufficiency? Or do they have a reason for renal vasoconstriction? So when the creatinine is elevated, what is the pertinent history? Fluid loss, diarrhea, vomiting, burns, surgery, and shock. Nephrotoxic agents. 84% of non-critically ill patients at a tertiary care center like yours are receiving at least one nephrotoxic medication. Next to hand washing, it is the #1 most prevalent environmental exposure. And it's something we can alter. And so we need to make sure patients are getting the nephrotoxic medications they need only for the time they need them. Glomerular disease. So there are a number of signs and symptoms that we are all aware of. And then we always have to think about obstruction, especially in patients with congenital anomalies of the kidney and urinary tract. Let's just talk a little bit again about aminoglycosides. These are data from Texas Children's Hospital again. And what you can see here in over 500 patients who received an IV aminoglycoside for more than 5 days, depending on the acute kidney injury definition, 1 in 5 to 1 in 3 of them had AKI. But serum creatinine was measured at least every 4 days, only 50% of the time. So we have to think about reliable acute kidney injury surveillance in patients who are on aminoglycosides. And another study that we performed at Texas Children's showed, as I mentioned before, 86% of non-critically ill patients are exposed to at least one nephrotoxic medication. And when patients, these are non-critically ill patients, are exposed to 3 or more nephrotoxic medications on the same day, the risk for AKI more than doubles. So just keep nephrotoxicity in the back of your mind. So the creatinine is elevated. What should I look for on exam? Signs of volume depletion, signs of AKI like edema and hypertension, signs of an underlying kidney disease for glomerulonephritis, fever, macular rash, palpably enlarged kidneys for small infants, and signs of obstruction. So the creatinine is elevated. What tests should I order? Now it gets really interesting. So let's think about the clinical tests. Well, AKI diagnosis now and then hopefully soon. So we used to call this pre-renal azotemia, and we still do for patients who are intravascularly depleted. But I would like you to start to use the term functional AKI, and here's why. There is decreased perfusion to the kidney, but it is not synonymous with dehydration. Although you will hear, oh, this patient is just pre-renal, let's give them fluid. It is not synonymous with dehydration. It is not synonymous with dehydration. So I hope I've made my point. Some pre-renal states should be addressed with fluid restriction and not with fluid administration. And I'll talk about those in a minute. Then what we used to call intrinsic AKI, let's turn this term into structural damage. Acute tubular necrosis. There are data that show that patients we diagnose with structural damage actually do not have necrotic tubules. So let's be careful and not just use old terminology. Glomerular nephritis is an intrinsic structurally damaging AKI, but it does not cause tubular damage. Acute interstitial nephritis, and then post-renal AKI, we can call obstructive AKI. So in the ADKI group, which was the group that gave us rifle, we came up with this concept of functional change, damage or structural change. And this 2x2 table really helps us. Biomarkers have helped us really understand associations with the different types of acute kidney injury, functional versus structural, and outcomes. So let's get back to what diagnostic tests we should try. A urinalysis never hurt and doesn't cost much. So get it all the time if you can. A renal ultrasound never hurt, but it does cost a little more than nothing. So get it most of the time. These things are non-invasive and can give us a lot of information, except when the diagnosis is obvious. Nephrotoxic medication-associated AKI is the most common cause of AKI in the hospital. Non-oliguric AKI is almost always nephrotoxic medication-associated AKI until proven otherwise. And that's why it's important to screen, because patients are non-oliguric, and so you need to screen with creatinine to see if there's AKI. So the NINJA program, which we developed, really highlights the benefit of screening for nephrotoxic AKI. In the first work on NINJA, patients who were non-critically ill receiving 3 or more nephrotoxic medications on the same day, or an aminoglycoside for 3 or more days, had a daily creatinine assessed. And we had 99% adherence to that daily creatinine. Over 3.5 years, just by educating the physicians at Cincinnati Children's about nephrotoxicity and AKI, we were able to achieve a 38% reduction in high nephrotoxic medication exposures. And when we looked at the AKI rate over that period of time, we were able to decrease nephrotoxic medication AKI by 62% over 3.5 years. And if we look at how much AKI and exposure we avoided, remember, I never told anybody they couldn't use any nephrotoxin. I just wanted them to follow creatinine. We avoided in 3.5 years 633 exposures and close to 400 AKI events, just by paying attention and being thoughtful about the nephrotoxic medications we were giving. We then looked at Ninja at a number of different hospitals because we have many resources that other hospitals may not. Other hospitals may have resources we didn't have. And so over a 2-year period, we looked at the implementation of Ninja at 9 US hospitals, recently published this year. And again, we have found a 23% decrease in acute kidney injury across these 9 hospitals. So Ninja can work at other hospitals, and I can tell you, as we've continued to go after this publication, we've decreased the AKI rate even further. So this is something any hospital can do. You do not have to be a quaternary center. And this is something we can adjust and modify. One of the few modifiable risk factors for acute kidney injury is nephrotoxic medications. And in the collaborative, we avoided 242 episodes. This shows you that we decrease the AKI rate in exposed patients by about 30%. And but we still have 1 out of 6 patients who are exposed in one of those 2 ways getting AKI. So we need to understand other factors that may be contributing to the acute kidney injury in the exposed patients. So what are common causes of functional AKI? Intravascular volume depletion, decreased cardiac output, peripheral vasodilation, and renal vasoconstriction. So functional AKI assessment, you can look at the fractional excretion of X, Y, or Z, serum albumin, urinalysis, electrolytes, sputum, and creatinine, weight. Should always look at these if you can, and then an ultrasound and echocardiogram if that makes sense. There are a number of urinary studies that you can use, and looking at the sediment never hurts. Looking at osmolality never hurts. And there are a number of fractional excretion methods that are good screening tools. They can be very, very specific, but not incredibly sensitive. So the sediment, most in casts, you'll see GN, acute interstitial nephritis, vascular disease. If you see certain cells, pyelonephritis, acute interstitial nephritis, fractional excretion of sodium is great, if not on diuretics. Fractional excretion of urea, a low value can be helpful. And I didn't know you could do a fractional excretion of lithium or uric acid. Who knew? But people have published on that. If you have availability to look at lithium, good for you. We don't have it here. So how do we manage it? How do we manage the patient? The question to ask is the patient fluid overloaded or not in functional AKI management? If yes, then you have to think about congestive heart failure, nephrotic syndrome, and hepatorenal syndrome. If no, then you have to think of dehydration, hemorrhage, or sepsis. If the answer is yes, assess serum albumin status and replace. Fluid and sodium restrict. Diuretics if appropriate. Again, these are pre-renal states. Nephrotic syndrome, congestive heart failure, and hepatorenal syndrome are quote-unquote pre-renal states. We do not want to give those patients fluid. So we need to get away from the term pre-renal and call it functional AKI. If the answer is no, replace fluid and reassess. Another set of pearls. Intravascularly dry, fluid overloaded patients with functional AKI should not get more fluid. Making the creatinine look better doesn't make the kidney function better. That being said, making the creatinine look worse in a fluid overloaded patient that you diurese is not making the kidney function worse. You have to understand that creatinine is a functional marker, not a structural marker, and you have to take it into context. The C in ABC is not creatinine. If you understand these and realize that many who consult you don't, you get to call yourself a nephrologist in public and you have job security. Common causes of intrinsic AKI, acute tubular necrosis, renal vascular disease, interstitial disease, glomerulonephritis. So acute interstitial nephritis, withdraw the medication. There are data to suggest that urine eosinophils, again, may be very specific, but not terribly sensitive. And should we use steroids? In GN, get the complements, look for anti-GBM disease and ANCA disease in patients who have pulmonary signs and lupus if the history suggests risk factors for lupus. Thrombotic microangiopathy, look for TMA, look at the CBC, platelets, LDH, and haptoglobin. And renal microangiopathy or atypical HUS, call Brad Dixon in Denver because I can't keep up with all of the different genetic variants. So what about structural AKI assessment? Get a patient weight, strict I's and O's, blood pressure, electrolytes, calcium, phosphorus, serum albumin. In the ICU, calculate percent fluid overload. And if the patient is receiving invasive mechanical ventilation, then please evaluate oxygenation status. And then think about where you are in the phases of acute kidney injury to determine what your management should be. If you're in the early phases in the functional pathway, then determine if you need to fluid restrict or give. In the extension phase, are there things you can remove? In the maintenance phase, do you need to think about renal replacement therapy? What are the available options that have been studied? Diuretics, phenoldiazepam, and dialysis. Conservative management of AKI involves diuretics to increase urine output, improve fluid balance, permit delivery of fluid to the patient, such as nutrition and other therapies, and it may augment the loss of potassium, which can be helpful. But wait, why are we talking about dialysis? What about furosemide? Vitamin L always works. Well, it doesn't, and in randomized studies, it has never been shown that giving diuretics prevents the need for dialysis. That being said, I think everybody should get a trial of diuretics, and if diuretics provide you with enough urine output to give all the blood products, nutrition, and medications you need without getting the patient volume overloaded, then continue with diuretics. But if diuretics are not giving you that volume, then you need to think about either fluid restricting or renal replacement therapy. And in an ICU, fluid restriction can be dangerous because patients aren't getting the nutrition or blood products they need. So when do we think about starting renal replacement therapy? Well, clearly for life-threatening electrolyte abnormalities not amenable to medication management. Exogenous or endogenous toxins that are amenable to dialytic removal, treatment of fluid overload, and where we've done a lot of work is prevention of worsening fluid overload to allow for blood products, medication, and nutrition. The treatment options, we all know peritoneal dialysis can be done anywhere, hemodialysis, and continuous renal replacement therapy. So we started, again, about 20 years ago looking at fluid overload in kids who were receiving CRT. And as I mentioned, nephrotoxic medications are one of the modifiable risk factors for acute kidney injury. So is when we start renal replacement therapy based on fluid overload. This initial study out of Texas Children's looked very small, looked at 22 kids who received 23 courses of CRT over the study period. Survival was about 40 to 45%. And we calculated the fluid overload at CRT initiation, which was fluid in liters from ICU admission to the start of CRT minus fluid out in liters from ICU admission to the start of CRT over ICU admit weight in kilos and multiply by 100%. So we just are looking at ICU fluid accumulation. What we found in this early study that about 3/4 of deaths occurred in the first 25 days of ICU admission. But the big outcome of this study was demonstrating that kids who died were on average 35% fluid overloaded at the time of CRT initiation, where kids who survived were about 15% fluid overloaded. And when you controlled for severity of illness, the fluid overload was still independently associated with mortality. But let's think about these numbers here. So let's pretend we have a 30-kilo patient admitted to your ICU. Patient who's 15% fluid overloaded, that's an additional 4.5 liters of fluid. Positivity. Patient who's 35% fluid overloaded, that's an additional 10.5 liters of fluid in a 30-kilo patient. So more fluid is not helping that patient. And the question is, do patients really need that fluid? And maybe starting renal replacement therapy could help. Well, a number of other single-center studies and a multi-center study from the Prospective Pediatric CRT Registry group have demonstrated that in every study, patients who died were significantly more fluid overloaded than patients who survived. And the numbers you see here are pretty similar across the studies. And when we looked at different fluid thresholds in these studies of 10 or 20%, it seemed that this was a threshold that really made sense. That patients who got to greater than 20% fluid overload had significantly increased risk of mortality. And so now we try to prevent that degree of fluid overload by starting renal replacement therapy before that. Those were mostly single-center studies, so we then developed the Prospective Pediatric CRT Registry group to put in more patients. And this study by Scott Sutherland from 13 centers in the PPCRT looked at 3 levels of fluid overload: less than 10%, 10 to 20%, and greater than 20%. And what you can see is mortality increased with each fluid overload strata. And while the rate of multi-organ dysfunction syndrome was greater in the middle fluid overload group compared to the least fluid overload group, there was no statistical difference between the middle and the most fluid overloaded group. That's the same association was seen in sepsis. More sepsis in the middle group than the lower group, but no difference between the middle group and the upper group. As was the risk of mortality score, no difference between the middle and upper group. So you could say by every measure, patients in the middle group who had higher mortality than the least fluid overloaded group had higher severity of illness. But by no measure did patients in the greatest fluid overload group have greater severity of illness than the middle fluid overloaded group. So there were no objective data to tell you that patients needed to get to greater than 20% fluid overload prior to CRT initiation. And when you put these data into a multivariable risk model, fluid overload was still independently associated with mortality when controlling for multi-organ failure, cancer, and sepsis. Now, you and I cannot control if a patient has cancer, multi-organ failure, or sepsis, but we can control when we start renal replacement therapy based on fluid overload. And the odds ratio for mortality when kids got to greater than 20% was 8.5, higher than that of cancer, higher than that of sepsis, higher than that of multi-organ failure. So what do we think's going on here? Well, Dr. Aisha Ericon at Texas Children's Hospital looked at fluid overload and oxygenation index in critically ill kids who were intubated and ventilated, but not on renal replacement therapy. And what she found was, interestingly, at 15% fluid overload, the association with fluid overload and oxygenation index became statistically significant. A higher oxygenation index means that patients have more pulmonary edema. They need more mean airway pressure or a higher FiO2 to get the same PaO2 on the blood gas. This suggests the fluid is going into the lungs, and we know dialysis doesn't remove fluid from the lungs. So we need to have a preventive strategy, which is why 15 to 20% fluid overload really should be a marker to think about starting renal replacement therapy, whether it's CRT or peritoneal dialysis or hemodialysis. And so when I think of fluid balance in the ICU, I think of this way. Yes, early on, the patient needs to be resuscitated. But once the resuscitative phase is complete, then let's think about a maintenance and homeostasis phase. And you can see here, I'm not recommending early fluid removal. What I want to do is help the intensivists keep fluid balance even at less than 20% fluid overload, but allow them to give all the blood products, nutrition, and medications they need without getting the patient more fluid overloaded. If that can be accomplished by diuretics, great. If it can't, then we need to move to renal replacement therapy. And then once the patient is stabilized, we start to remove fluid and wait for renal recovery. So in conclusion, acute kidney injury is common in hospitalized children. It is associated with poor outcomes in hospitalized children. Understanding the type of AKI in the differential, functional versus structural, can optimize diagnostic and therapeutic intervention. And finally, limiting unnecessary nephrotoxic medications and or unnecessary fluid overload are the only modifiable AKI risk factors we have and may improve outcomes. I want to thank you for your attention and the kind invitation. It's been a pleasure to speak with you. I'm happy to take any questions for a few minutes, or Dr. Ganesan can give you my email, and I'd be happy to answer any questions by email. Thank you so much.
Thank you so much for the enlightening talk, sir. Your years of research was very much evident in your presentation, and I'm sure you would have kept virtually every member of the audience hanging on to every word of your talk. Thank you so much, sir. It was an excellent presentation. And can we take up the questions now, sir? We have few questions in the box.
Yes, can I read absolutely. Out? Yes. Oh, can I read them? Let's see.
In nephrotic syndrome, already have oliguria. Is it better to categorize AKI based on serum creatinine or the urine output?
I would call it functional AKI based on the creatinine, but to understand that fluid restriction is really critical, which is why daily weight is the most important vital sign in all of nephrology. So following the daily weight is critical. And since it's a quote unquote pre-renal state, it's not going to get better until the albumin is improved.
Okay, and so the criteria of taking up serum creatinine is best in nephrotic syndrome children?
Yes, absolutely, absolutely.
Okay, fine, sir. And the next question is, timing of initiation of RRT in acute kidney injury is still controversial. What's your take on that?
Yeah, so it is very controversial, and all of the studies have looked at serum creatinine-based definitions of AKI, KDIGO stage 2 or 3. And what I think, what they have not looked at is fluid overload. And when a patient becomes very fluid overloaded, their creatinine actually doesn't rise as quickly because creatinine is a concentration. And so while the studies have not demonstrated, most studies have not demonstrated a benefit of early initiation based on creatinine, all of our observational data in children tell us that starting between 10 to 20% fluid overload is associated with better outcomes. However, we do not have a prospective randomized study of that yet in children, but that's going to be difficult to do because I think we've lost equipoise. I don't see why I would allow a patient to get greater than 20% fluid overloaded just to prove a point that it's in a prospective study, since we are all good at doing renal replacement therapy, why would we limit it? Or I would have to tell the mom in bed space too, we're going to let your child get to 30% fluid overloaded to prove a point. What we're trying to do with our research and with others is to use risk stratification, biomarkers, and other tools to tell us who are the kids who get to greater than 10% fluid overload, who are going to recover soon, so we don't need to start renal replacement therapy. Renal replacement therapy in the ICU is the only area that I'm aware of where the intensivists need us or want us to be 100% right. But and so they'll ask me on rounds, how do you know this patient needs renal replacement therapy? And I'll say, well, I don't know when their kidneys are going to recover. And until I have a better diagnosis, fluid overload is the most important. But then I'll ask them, I'll say, is every patient you send for an MRI have an intracranial mass? Is every patient you intubate, are you sure they needed to be intubated? Is every patient that you do a lumbar puncture on have bacterial meningitis? Because I would say if you had 100% sensitivity to pick up meningitis, an intracranial mass, or respiratory failure that would not get better, you are not doing enough MRIs, you are not doing enough spinal taps, and you are not intubating enough patients. So don't ask us to be 100% accurate when that doesn't exist in medicine. Give me a reason why I would not start renal replacement therapy when a patient is 15% fluid overload, other than I hope they'll get better. That's not a strategy. I'm happy to take it.
It was excellent.
Not my first time I've been asked that, and you can quote me on that one. You're not doing enough, whatever you think it is. I'm happy to take a few more, one or two more questions, and then please give them my email, Dr. Ganesan, and I'm happy to answer by email.
Okay. The next question is acute kidney injury stage 1. Do fluid restriction still holds good?
It depends on the patient, right? So if the patient has stage 1 functional AKI and it's very clear they have acute gastroenteritis or they have hemorrhage, then no, they need to receive fluids. And so that's why not all stage 1 AKI or stage 2 AKI or stage 3 AKI are the same. So you need to evaluate the patient and say, is this functional AKI? And if it is functional AKI, is it true volume depletion, or is it a systemic disease with a pre-renal state like nephrotic syndrome or heart failure or hepatorenal that should have fluid restriction? So it really depends on what the underlying diagnosis is.
Okay, and the next question is an interesting question. In sepsis-related acute kidney injury, is it better to wait for antibiotics to work or wait for RRT to go immediately, or RRT along with IV antibiotics?
Yeah, so really good question. And people have looked and thought that renal replacement therapy, even at high effluent rates, could improve outcome in sepsis. The Dr. Ronco hypothesis that you could remove pro-inflammatory cytokines. As much as I love CRT, and it's my favorite thing to do, I don't believe that CRT is an effective treatment for sepsis. The data are not conclusive in that way, and the amount of pro-inflammatory cytokines that are generated in sepsis are not rapidly and easily removed at significant rates by CRT. That being said, I do hemofiltration, so CVVHDF, because we know convection will remove cytokines better, and I do use membranes that may have some absorption of cytokines because maybe there's an incremental benefit. But yes, you can quote me, Stuart Goldstein, that I do not use CRT to treat sepsis. So let the antibiotics work, and if the patient develops 10% fluid overload and septic, then start CRT.
Okay. And the next is
I'll take one more, Dr. Ganesan, okay? Because I do have a conflict.
Okay. And the next question is, it's not a question, it's rather a compliment. Greetings from Karachi to Dr. Goldstein. You're the pioneer in concept of renal angina and renal angina index. Is it obsolete now, or newer concept has taken over?
Well, that's very, very nice. Thank you so much. So we are still evaluating the renal angina index. And we're very proud that others around the world have taken it up, and it seems to perform beautifully. And we're looking at the RAI in sepsis. We are looking at the renal angina index in the emergency room. And actually some adult colleagues are starting to look at it. So yes, we are using the renal angina index to help us determine in which patients do we get biomarkers and in which patients do we have a higher confidence in starting renal replacement therapy. There's a beautiful multi-center analysis or multi-study analysis by Dr. Abbasi in the Archives of Emergency Medicine that was just published, and none of the usual suspects like myself or Dr. Basu had anything to do with it, and I recommend that paper to you because it shows across many pediatric populations that the renal angina index works quite well. Thank you so much for the compliment. And thank you again, Dr. Ganesan. I do need to go to another conflict, but this was a lot of fun, and please forward all the questions to me, and I'll be happy to answer them over the next few days. Thank you.
Sure, thank you. Thank you so much, sir. Thank you for your patience. And we had a lot of technical issues initially. You really helped us out to sort it out. Thank you for the excellent session, sir. Thank you so much.
Thank you. Good night to you all. Take care.
Good night, sir. Thank you, sir. Bye-bye, sir. Thank you so much.